I did not retire when I wanted to. I anticipated working for at least 2-3 more years because I enjoyed what I did. We used to go to Nevada or Arizona, and I used to do the rock climbing. When you get the shakes, like I'm getting right now, you can't rock climb. It impacts also in your social life because I also belong to a couple of clubs with model railroading. When you have the shakes, you cannot put a kit together. So you end up withdrawing.
It's estimated that anywhere between 20 and 40% of people with Parkinson's disease will experience depression at some point during their illness. So as part of our routine clinical care, every patient with Parkinson's disease completes something called the Geriatric Depression Scale, which is a 15-question yes or no tool that we use to try to help detect depression in Parkinson patients. When Mr. Knight started to come to see us, we were noticing that his scores on the Geriatric Depression Scale would very much fluctuate. However, once he started to really endorse feelings of poor motivation and lack of interest in his life, that's when we decided to refer him on to Dr. Weintraub for possible treatment of depression.
Okay, Mr. Knight, you can have a seat and a nurse will come out and call you shortly.
Good, thank you.
You're welcome.
One of the tricky parts about evaluating Parkinson's disease patients for depression is that there can be overlap between the core symptoms of Parkinson's disease and depression. For instance, Parkinson's disease patients, by the nature of their illness, often experience change in sleep and appetite, concentration, experience slowness in movement, and amotivation. Those are also core symptoms of depression.
As the symptoms developed, I became much more withdrawn, where I don't go out that much. And the medications also impact your normal daily life.
It's difficult both for patients and clinicians to know sometimes whether to count those as symptoms of depression or count them as just symptoms of Parkinson's disease.
A lot of times when we hear that the person has backed out of activities or is no longer as socially involved, we do want to explore that to find out, is it because of the motor symptoms, is it because of an embarrassment, or is it because of an underlying depression, or maybe a combination of both?
Parkinson's disease patients sometimes have limited awareness of their own symptoms, and that's why we try to involve informed others or caregivers in the evaluation as well.
In Parkinson's disease, we're finding that it actually is quite common for the person to have some form of depression and not really be cognizant of what is going on.
Am I actually depressed, or I probably am, but I really use the word, I'm more apathetic to it. Lack of interest.
A lot of times, frustration and moodiness gets just blamed on having a chronic disease and trying to cope with that, when really there's a whole other issue going on with either depression or apathy or anxiety. So it's very important for the clinician to know the right questions to ask to be able to uncover these hidden signs and symptoms of depression.
It's very frustrating, and I guess you can say depressed, that this is actually happening to you, and your plans that you had made, you're not going to be able to accomplish them. Mr. Knight. Hello, doctor.
Once I interviewed him and confirmed that he did have mild depressive symptoms that would warrant treatment, we discussed the available options. One major route is to consider psychopharmacology or antidepressant medication. The other major route is to consider counseling or psychotherapy, and those two can be combined and often are.
While actual suicide is not very common in Parkinson's disease, something called suicidal ideation, or thoughts about, would I be better off if I was no longer here? Would my family be better off if I was no longer here? Am I a burden? How could I do this? We do know that that is relatively common.
You have Parkinson's, there is no cure. They have medications to work on the symptoms, but you can see that you can always be getting worse. The thoughts are there that, what's the purpose of me continuing on here?
Moving from that point to actual suicide is not very common, luckily, in this population.
I have no desire to do myself in. That's not a concern. Sometimes I think, though, that if I stop taking my medications, what will happen? My world hasn't gotten smaller, it has shrunk. And it's really the lack of interest, or I'm not sure exactly what it is that I have been, or I am withdrawing into my own little world.
He's tried 2 different antidepressant medications, but because of side effects or concerns over side effects, he hasn't really been compliant and hasn't chosen to stay on these drugs.
The only problem with the medication that he prescribed tossed me for a loop. I stopped taking that.
It does take some tweaking. We don't always find the right drug the first time around, so working with a psychiatrist or working with the neurologist is very important. Giving the drugs a couple of weeks. If that drug doesn't seem to work or there are side effects, we have a whole spectrum of different types of antidepressants that we can use.
I'd like to see if we can form an alliance where we can get him to get to an adequate dosage for an adequate period of time to really evaluate its impact on his mood. In his particular case, it may have a secondary benefit of helping some of his chronic pain symptoms as well. Clinically significant depressive symptoms are common in Parkinson's disease. They can occur at any stage of the illness. It's important that both patients and informed others be aware of that and be willing to discuss those symptoms and answer questions when they're coming in for evaluation with their neurologist or Parkinson's disease specialist. And to also recognize that we do have treatments now, whether it's medication or psychotherapy and counseling, that do appear to be helpful for the treatment of these symptoms.